Okay. I think we are now live, so let's pick up with the Kodachrome session. So, Rob, what do you think?
So, I mean, looks like kind of whitish reticulated patches, more inferiorly into the side.
Yeah, so there's a little bit of what's either exudate or...
hard to tell if it's
I think in this case that was exudate, and the lesions that brought the patient in were these.
Oh, okay. So kind of reddish papules, almost vascular looking.
Yeah.
So, I mean, you could think about like an angiokeratoma.
Exactly. So, we see a lot of Fordyce angiokeratomas in males, but you see exactly the same thing in females. So, remember, anatomically, labia majora is equivalent to scrotum, and labia minora is equivalent to urethra in the male. In terms of things that you would see in both conditions, those are analogous.
So it's kind of external job, like angulated ulcerations, some erythema.
So some of this, there has been so various things have taken place. You can see a radiation mark. So there has been breast surgery for cancer, there's been reconstruction, and then since the reconstruction there have been numerous kind of cold indolent abscesses.
Maybe like atypical mycobacterial.
That's what's at the top of the list for that. You have cold indolent abscesses after any kind of a plastic surgical procedure. It's usually AFB. And that's what grew. Routine culture often grows nothing on it. The things you tend to miss in routine culture, fungi other than yeast. Candida grows fine in routine culture. Anaerobes. When you're growing coliforms, what you're not growing is all the anaerobic gut bacteria that are probably causing the infection. And then AFB requires special media. So if you're doing empiric therapy for AFB, because they can be slow to culture and get sensitivities, right? So empirically for mycobacteria other than tuberculosis.
You can do like minnow or...
So minocycline is kind of the old one that we still use for M. marinum. And then clarithromycin is the one that empirically on antibiograms has the broadest coverage for atypical mycobacteria currently. The question is, do you use it as solo therapy, which you can for many cutaneous infections? More serious infections you would always want to do with rifampin or with something else. Triple drug therapy is very common. She ended up on triple drug therapy. When it's purely an abscess, drainage alone will heal a lot of atypical mycobacterial abscesses. Unfortunately, by the time we saw her, she already had excision of areas that were thought, when they weren't sure what was going on with, grafting, that you can see the results not very good. That's going to have to be repaired at some point. And she's had numerous attempts at drainage, which have resulted in persistent draining sinus tracts.
We have the right perinasal lower lid area. The see a lot of footage everywhere is changed to red, white, brown. Obviously, like immediately in the lower lid, there's lots of lashes. I've seen this, but you'd be concerned about some sort of infiltrative process on the lower lid there. Like
Yeah,
lots
you
of
certainly
lashes,
would,
maybe
right?
basal cell or something along those lines.
Exactly. So the question is, one, has there been radiation here previously to try to treat something? This could be radiation change. Radiation is problematic on lids. Right now we're treating an MF patient who has isolated tumor of MF on his upper lid. In other areas, you'd go right to electron beam and just fry the thing. But on a lid, you're going to be left with, unfortunately, he goes medial. So you can fry your nasolacrimal duct where your eye waters forever, and yet, because you've fried your sebaceous glands, it feels like a dry, irritated eye that's forever watering. And then grit gets in it because you lose your lashes. So, lots of baggage, potentially with radiation on an eye. And the other would just be like a morpheoform BCC or even sebaceous carcinoma that's infiltrative. Or it could be a dermatosis. That could be morphea or LS. So it's obviously going to be biopsy diagnosis at this point. That's a wider look at that eye.
Liquidermis CTCR.
Possible, although I see a lot of depigmentation here. I also see a depression that suggests that there's some mass lesion in there, filling up the area. And that I think it turned out just to be BCC, but sort of nasty, widespread morpheoform BCC.
Yellow bullet or some serum that they were made on pustule or some other kind of process on the inferior side.
Yeah, so there's certainly crust there, and it looks denuded with a keratotic rim, like there has been a blister there. So my guess is that this is a fresh blister and that these are where prior blisters have been. And where do you think you are anatomically?
Either way.
Yeah. I mean, given that there's hair loss there, that tends to be a lower extremity thing. Right, so, probably a shin. So what are you thinking?
I mean, they're not as, the other ones look like they weren't as tense, but maybe BP, maybe something that's, it would be kind of a weird rotation for like a bolus.
Yeah, it would be odd for bullous tinea. The surrounding tissue doesn't look like bullous lymphedema, particularly, right? So BP's probably highest on the list because it's really common on the shins. So how are you going to diagnose it?
Well, hopefully they have some on their trunk because that's a higher yield.
Yeah. So, obviously part of what we're getting at is that you have a 1/3 rate of false negatives for IF on the lower leg. There was just a paper that came out on using C4A or C4B. That's a new fraction that you can do on immunofluorescence that was positive in a significant percentage of false negative BPs. The other thing, if they have nothing anywhere else, sometimes you try for the ELISA, which only has an 80% sensitivity, so you're going to miss 20% there too. Sometimes it's just routine histology or just treating empirically like BP. So how are you going to treat localized BP on the leg?
Just talk with steroids. Probably.
Yeah, I mean, you're going to start with just steroid under occlusion, and then when that fails, doxyniacinamide's a reasonable next step. He's got bad reflex, can't tolerate that, or it's not working. Where else do you go?
Some of them immunosuppressants, localized.
Yeah, so obviously azathioprine, mycophenolate, but prior to that, Leg BP is often neutrophilic as much as it's eosinophil rich, and dapsone and even colchicine may be worth a try when you're trying to keep an older patient off of immunosuppressants. One thing we have a problem with Epic builds here where we have a 2-year wait list to get anything changed in a smart set. So our current smart sets for high-risk drugs have the old recommendations for hepatitis screening in them. So they don't have our acute hepatitis panel built in. What you're missing is core antibody. So if you use SmartSet, like methotrexate SmartSet, you're missing core antibody. And core antibody is now a boxed warning on rituximab because there are patients. It used to be thought that core antibody positivity was old healed infection and you were immune. That has changed because of the number of patients who've died on rituximab of reactivated Hep B who only had a core antibody positive. So now they say it's past infection and you don't know if they're immune or not.
Even with a surface antibody?
If they have a surface antibody, they're immune.
Right, okay.
If all you know is that they're surface antigen negative, but core antibody positive, is they've had past infection and you don't know if they're immune or non-immune. And they need further evaluation, and that is now a boxed warning for rituximab. There was one patient at MUSC who died of fulminant hepatitis on rituximab having been surface antigen negative. So it's, and that's not just here, it's nationwide that's happened. So there is a boxed warning on Ritux expected in the future on most of the other immunosuppressant drugs we use. So it's a major paradigm shift where that used to be thought to be immunity, and now they're saying past infection, you don't know if they're immune or not, and there is some risk. Paper that just came out in JAMA, I think, that looked at biologics. Biologics had a very low risk of reactivating when only core antibody was positive. Now, rituximab also has a very low risk, but there's still 20 dead people. So, the question is how low is low enough? And for us, we have a problem because we built the smart sets so that you wouldn't forget things that were important, but MUSC makes it difficult for us to update smart sets. So the hepatitis screening is out of date on our smart sets. That's the only thing currently that's out of date there.
What do you do with a patient that has that situation where you want to start them on the tux?
So if they're core antibody positive, you may need a different drug. I would certainly do it in conjunction with hepatology, and they may want to treat or at least follow the patient. Unfortunately, the people who've died of hepatitis, it's been an acute fulminant hepatitis, and their treatments made no difference. So, and most of those cases were fatal. So, it's a big change, and it's a safety risk for us in that our smart sets they don't have all the screening in them that we would want. So okay, so how about this patient in comparison?
So it looks like you have a lot of superficial erosions, and then there is one core.
And is this one as tense, or is this not near as tense? So you're thinking that this is a deeper or a more superficial split? And so what kind of things are you thinking?
So it could be more of a PD.
Yeah, so it could be vulgaris. Could even be foliaceous, although it's rare to see, any intact blister with foliaceous.
Other things that affect desmoid 1, bullous impetigo.
Correct. Bullous impetigo, again, is a more superficial split. You can get it's the same level as foliaceous, and yet you're a little more likely actually to see the bulla in bullous impetigo than in foliaceous, where you rarely see the blister. The other thing is when you have an erosion, and at the periphery of the erosion you have multiple new bulla, put IgA in there. It would be unusual for it to be so flaccid, but the morphology of the lesion suggests IgA. It's going to be a biopsy diagnosis, obviously, for both IF and H&E. Where are you going to get your H&E, and where are you going to get your IF?
So H&E lesional and IF would be
Perilesional. And we used to say a centimeter away from the lesion. Now there's data from Mayo that if you have urticarial lesions, so you have fresh erythema that's not yet bullous, that has a higher yield than the normal uninvolved skin. So non-bullous, fresh lesional skin has an even higher yield than normal adjacent skin. And bullous disease is the only time where you're not going for lesional. Things like lupus, connective tissue disease, you're going right for well-established lesional skin. Okay, how about here? And what if they're not pustules? And what if it's so you have erythema where there have been popped blisters. What else could they be if they're not pustules? Milia. So porphyria has, this particular one is just BP. But EBA, your blister is likely to be subepidermal blister if you're getting milia. The only exception to that is Dowling-Meara type of EB simplex. You're going to think it's a deeper blister EB because of the presence of milia. So Dowling-Meara is an EB simplex that mimics a scarring dystrophic EB because of the presence of milia. And so, this is all just extensive milia in a BP patient. She is now on Ritux, which we are getting covered for BP sometimes. Okay.
So this looks like is that breast?
That is breast, correct. So that's nipple areola.
So 7 thickness is chronic.
Correct, and it's smelled to high heaven.
Very well defined. You could think like PG.
Yeah.
It's like smelling.
Yes, in fact, Shane can probably still smell the lesion, having spent a long time debriding. So this is a patient who has end-stage renal failure. She has behaved at times, a lot of you have seen her, that she's behaved like calciphylaxis, but we've never been able to prove it on biopsy. She definitely has exhibited pathergy, and she's responded to Humira among other things. But at this point, she had no active inflammatory phase of PG. She has no follicular pits. She has no active undermined area. This is, after what was probably a PG ulcer, and she just has horrible anaerobic infection through this huge mass of nasty necrotic stuff. And, we were taking a couple of pounds of just nasty necrotic stuff out. And then with initially just intralesional corticosteroid, and then later Humira, we prevented pathergy, and the breast completely healed. She's also had a fulminant large vessel vasculitis that came out of the blue antibody negative, no drug implicated, and she lost a leg and most of her fingers to that. So, horrible disease. In terms of covering the anaerobes, so, part of it in this case was cold steel, and we weren't getting into viable tissue. We were just taking out dead necrotic stuff. There's no risk of pathogy because you're not inviable. The greater risk of pathogy is actually from your injections. So if you're injecting through viable normal skin anesthetic, that's where you're going to get your breakdown and pathogy is every needle stick site. So classic pathogy is you're less likely to get it from an abdominal surgery and more likely where they drew your blood for the CBC. And it's thought to be a histamine trap phenomenon where immune complexes form where you have the histamine release from the needle stick and then you get a little pustule and it expands from there. Testing for pathogy, like a Behçet's patient, you just take a needle and you just do little 30-gauge needle jabs and you see them 24 hours later, and if they have a series of little pustules there, they have pathogy. So how are you going to cover anaerobes? Thank you, David. Rachel thanks you for that, because as you were lowering it, I could see this. If the sun is ever in your eyes, get up and lower the shade. So anaerobic drugs. So Clinda hits pretty much all anaerobes effectively. What do penicillins hit? Above diaphragm anaerobes effectively. So above diaphragm anaerobes, like if you're getting, like my son just had his wisdom teeth out, the infection there is going to be fusospirochetal or anaerobic, oral anaerobes, and so they still put you on amoxicillin when you get your wisdom teeth out. Above diaphragm anaerobes do okay with penicillins. Clinda does below diaphragm anaerobes, and then the other drug you can use is Flagyl. Flagyl has decent gram-positive and decent anaerobic coverage. Both Clinda and Flagyl will miss some enterococci. But some of those are even vancomycin resistant, right? So, and Flagyl is metronidazole, of course.
How do you? What's the difference between kebnerization and pathogy?
Okay. So there is kebnerization and there's pathogy, and there's Wolff's isotopic response, which are three different things. So pathogy is acute suppurative inflammation at a site of minor or greater trauma. Kebnerization is an injury that produces, that a dermatosis localizes to. Like you've had an abdominal surgery and you get psoriasis in the scar. Or you scratch your psoriasis and worsen it. That's kebnerization. Or you burn someone with phototherapy and their psoriasis gets worse rather than better. And then Wolff's isotopic response is where you have not an injury but an inflammatory something that then a second inflammatory something localizes to that area, probably because of vasodilatation and various other things. So you'll see people who get EM that localizes around surgical sites or nevi or other. You get a bullous disease, and then later LP shows up in that area. Things like that are Wolff's isotopic. So.
What about like diffuse dermal angiomatosis? Or would you ever think of that?
For this?
Yeah, like
so
pendulous
that
or-
tends to be under the breast, not the surface.
Okay.
So it's usually pendulous breasts. It's a manifestation of ischemia, and so most commonly it's the undersurface of a heavy breast where that compression is giving you chronic ischemia. And the problem with the diffuse dermal angiomatosis is just like atypical vascular lesion after radiation, a percentage of them go on to angiosarc. But it is a proliferative response in response to ischemia. So heavy pendulous breast or pannus, but most commonly on the underside of it. Okay, so that's a scrotum.
It looks like there's some white molecules.
Yeah, so there are things here, right? So what's your differential?
6.
Yeah, so the EICs are common on the scrotum and eventuate over many years into idiopathic scrotal calcinosis. You know, those start as EICs and just calcify. So, but that doesn't tend to have surface change, right? Here, it looks like there's epithelial change. Probably it looks like there's acanthosis of some sort there.
You can get a lot of epithelial change if there's like rubbing LSD or
Yeah, so question, is there another lesion with superimposed LSC? Very reasonable thought. You know, could they all be just parigo? Could they be condyloma? So next step, biopsy, and these are all epidermolytic acanthomas. Epidermolytic acanthomas are kind of like a SEB that shows epidermolytic hyperkeratosis. 90+% of them occur on vulva or scrotum. And in this case, they were symptomatic, and so we just shaved them all off. But they were all, you know, it's a great location for it, epidermolytic acanthoma.
And so they're too white or for Fordyce or for angiokeratomas?
Correct. So Fordyce angiokeratoma, you can have hyperkeratosis over it, but they look distinctly purple to black or red to black shades. Okay.
So it's I believe it's a lower extremity.
Yep.
Central and ischemia to it's like nodules with central erosion with superficial crusting. Looks like we also have pinkish plaques that are around these areas with erosion as well.
And how would you describe individual lesions?
Well circumscribed.
Well circumscribed. Anyone else want to throw in something? Crateriform. And then it looks like you're getting another little one here, and maybe another little one there, and actually everywhere where the patient is scratching, you're going to get more of these. So what do you think they are? If she's a 90-year-old woman? Yeah. So eruptive KAs of the lower extremity are distinctly older women. You know, 70-plus-year-old women, anterior lower leg. You can see it in guys, but it's overwhelmingly women. And What happens when you take one off? 5 come to the funeral, right? That's the old quip. So how do you treat them? Chemo boots. So slather it with 5-FU, wrap it with Nunavut, do that every week till they're gone. For the really big ones, you may have to inject them with methotrexate or 5-FU. Methotrexate doesn't burn, 5-FU does burn, so usually 5-FU you either dilute with lidocaine or lidocaine the area first before you do 5-FU. You don't have to do that for methotrexate.
Inject and then wrap on the same visit.
I'm sorry?
Could you inject like those two?
That's exactly
two
what
and
we
then
did.
wrap?
That's exactly what we did. Is we injected methotrexate into these, put the thick layer of 5-FU, wrapped it, and most of them were gone in a week. It often needs a second wrap. Unfortunately, we've had some patients who have had it excised, read as squame, then all the others have popped up, and when we've seen the patient next, they've been on systemic chemotherapy and more potent regimens because these things keep erupting and they have more and more, quote, metastatic disease that's trying to be treated. So
You can't do them both at the same time.
I'm sorry.
You can do methotrexate and 5-FU. Is
Oh,
that
yeah.
what you're saying?
Yep.
So, like there's deep fissures in the tongue.
Yep.
So I'm not sure if that's just the acanthosis of the
Yeah, so fissured tongue, what things can cause fissured tongue?
Psoriasis.
Psoriasis is the most common, and on biopsy, the tongue shows psoriasis. In fact, it shows pustular psoriasis. So almost any patient with widespread or systemic pustular psoriasis will have a new onset fissured and geographic tongue. And both of those are manifestations of psoriasis commonly. What else?
There's a disorder with triad of the thick lip, the scrotal tongue, and then the cranial nerve 7 palsy.
Yep, which is Mischer-Melkitz and Rosenthal. We saw a patient yesterday with that. You can get it really bad oral candidiasis, really bad thrush. You can get fissured tongue. Some of the congenital syndromes like Beckwith syndrome, where you have the islet hyperplasia in the pancreas, and they have neonatal hypoglycemia, and they have partial gigantism, and they have fissured tongue. So, there's some syndromal things, but 99% of it is psoriasis.
All right, it looks like we have an extremity. There's some, right in the middle, there's kind of a pink patch.
So is pink the
Pink
only
to
color
violet,
you
just
see?
Maybe a little blue. There's pink and brown. I mean, there's brown macules within the patch.
Okay, so there are brown macules that exist beyond it as well.
Right.
And brown in skin can be what?
Hemosiderin, melanin, or lipofuscin.
Correct. And in this case, given that there's some KN peppering in here that's red, that's probably a little Schomburg's. That's unrelated to this. Right, so a little background capillaritis Schomburg's. Some of them may be lentiginous, but it looks like there's some red KN peppering in there, so maybe
There's
a
kind
little
of a
Schomburg's.
halo of yellow around it.
Yeah, kind of yellow or yellow-green. So yellow-green is
Breakdown of
bilirubin, biliverdin, which suggests that you had red cell
Trauma.
extravasation. Right, so it could be post-traumatic, or it could be anything else that was associated with red cell extravasation. And then you said that you thought it was maybe a little bluish too.
Mm-hmm.
So blues in skin come from what?
Tyndall effect of, inflammatory cells in the dermis.
Yeah, so it could be cyanosis or Tyndall effect of not inflammatory cells, but of brown pigment that when deep by diffraction appears blue. And, same reason the sky is blue. So then those pigments again would be melanin, lipofuscin, hemosiderin. with the yellow-green around it suggests maybe that it's hemosiderosis that's causing that. So it could be an eczematous pigmented purpura, Ducus capillacus type of eczematous pigmented purpura would be possible, superimposed on that. The other thing is when you see pink things that are round to oval and fade to blue or brown, you got to think of fixed drug too. The yellow-green ring would be a little outlier for fixed drug, but the rest of the morphology is good. The other thing you think are things like leukemia cutis, scleromas, should also be in the differential. And that particular one, I think, did turn out to be fixed drug. I don't know why there must have been a lot of extravasation during the fixed drug.
Just like annular plaques on the dorsal instincts
Yep.
makes you need a GA.
GA, does GA tend to have epithelial change?
I guess that one on the left does a little bit.
Yeah, you have definite epithelial change here, right? You
Yeah.
have depigmentation. GA is usually a dermal lesion with completely normal overlying skin.
Right.
Here, not normal overlying skin.
Okay. Yeah, I would have definitely said GA for this. So I don't. I would say, other annular processes. I mean, sarcoid's more dermal.
So sarcoidosis
aphoritic
also,
granuloma.
those are all more dermal
Right.
processes.
This
The other
way-
thing that suggests epithelial, see the light reflex there?
Right.
Suggests atrophy,
Okay.
right? So the skin is atrophic. There are
Ideally.
areas, so lupus, and this would be probably a hypertrophic lupus, if that's what it is. And then what's your big one that pairs with hypertrophic lupus in differential?
LP.
Yeah, hypertrophic LP.
Is that easy on the leg?
No, anywhere acral. So scalp, lips and tips. So lips, nose, scalp, hands, feet are hypertrophic LE, hypertrophic LP territory. So that would be my differential, is that this is hypertrophic lichenoid dermatitis. Lichenoid things are frequently annular, and they frequently are atrophic, and then you can get the mix of atrophy and PEH in the hypertrophic variants.
For that one, if you're doing GIF to differentiate, you just take it right from one of those violet borders, then right on.
Correct. You want active, well-established lesional skin for anything that's not immunobolus disease. Yep.
So, hypo and hyper
Yep.
pigmentation immediately makes me think of things that can be connective tissue disease origin, like scleroderma, crusty type things. Could be diffuse.
So in scleroderma, you tend to have depigmentation with retention of perifollicular pigment, right? Similar to what you see in vitiligo. Does this look like depigmentation? What do you think the patient's original skin color was?
I want to say that the changes are hyperpigmentation.
Yeah. So I'm guessing that this was probably the original skin color, and now you have both hyper and hypopigmentation.
And things like that too. Some about like GVHD type changes.
So I would go, doing broader categories, I'd go probably interface over eczematous to produce this kind of pattern of hyper and hypo. And then among interface, I'd throw connective tissue disease in there, but more likely a DM or lupus rather than a scleroderma. And graft versus host would be very high on the list, which is what this was. Graft versus host, when you see it clinically, it often accentuates around acrosyringium and follicle, around all the adnexal structures, which probably explains the drop-like pigmentary change. And this was someone, I think you guys saw this person at Grand Rounds. Oh, you saw him in clinic too, yeah. So bad.
Some drug did see, I don't know. I'll send you a gram around.
So, you can see how it's obviously very troubling to this individual. Okay, and we probably ought to stop here because I've got to get to the 8 o'clock meeting. So we are on set 7-151.
Thank you.
Thanks.
Thank you.